Hey, good morning, everyone. How are you all doing? We're going to get started, so if you want to take your seats. It's really great to see you all again. I know we had a week off, and so you got a little taste of having Saturdays to yourself. It was Valentine's Day, so I hope you got some extra special stuff going on in there. But we are very thrilled and excited to see you again and to keep the momentum going. You know, we're not going to slow down, so we're glad you're here with us to keep doing that. A couple of things. First of all, you know, Saturday mornings are a sacrifice, so we definitely appreciate you all being here. We know it's not a small thing. I know it's hard for me to get up in the morning, but I see you all and it's worth it. And we want to give a special thanks to our board as well that has been supportive through everything. Today we have one of our board members, Sylvia. I don't know where she's at. Oh, there she is. So just a special thanks to that, to say that we really are united at this organization to bring our best, so we're glad you're here with us to do what we do. And another thing is just that what we do for free. I know we say this a lot because it's true. It truly is a labor of love, in all ways, a labor of love, because I don't get paid, Jaime doesn't get paid, no one on the board gets paid. I'm a student, so I feel that not getting paid thing. But I'm really inspired by the people who I see, who I work with, how much they give around the clock all the time to make this possible. There are other organizations that are also committed to our communities and make these resources available, but they don't do it for free. So the money that we do have, the little money that we have, we invest in you all. Like, this is a free event for you all, but it doesn't mean it was free to put on. Money was invested, professors are paid, quality, the venue, all these things, but rather than put the burden of cost on you, we use what we have to make this available to you, because we know how crucial this information is, that knowledge truly is power, and this is a power that our communities should have had from the beginning, but now we're working to reclaim. So we do this for you. All of our classes, our academies in the fall, also all of the money goes into scholarships, because these things cost money and we want you all to have it. And so because of that, we are definitely always living day to day, stretching thin, as I'm sure many people can relate, always trying to figure out, all right, how are we going to do this, dreaming big and then figuring out how to make it happen. And I say all of that today just because we want to throw out a word of appreciation to somebody in the room. Don't worry, we're not going to embarrass you, we won't say who you are. But we very much appreciated getting some of that love back to somebody here today who was very generous in a wonderful act of solidarity, donated $2,000, to which we truly, truly want to say thank you. So thank you for being in it with us, in presence and in solidarity. Also another shout out, we're going to be doing a fundraiser event in June. You'll all get an email. If you'd like to help contribute, I know, we all don't have the monetary funds, but we also need volunteers. We need to spread the word. And so, let your experience speak for itself. If you want to stand in solidarity with us as we stand with you, this would be also a wonderful opportunity. So look out for that email. We'd love to have you really join in us to build this, because this needs to be what you need, right? And we need the money to make what you need happen. So with that, and so today we're talking about healthcare policy with Manny Rosa, who's over here. I'm going to do a quick introduction. He's done so many things, I had to write it down. We could be here all day again, but let me just highlight a few things. Since we're talking about healthcare policy, he's also very well experienced in that area. Not only does Manny have a lot of political experience, he also is one of our instructors for the Electoral Activism and Leadership Academy, so you could see him again if you like him today. He was the first director of the State Office of Minority Health, the assistant VP of HCC. He's worked in the governor's office twice. He's also worked for the New York State Assembly and Senate. And currently he's working with people with persistent mental issues, and also a professor at Queens College. So you'll see that, not only does he have a wide experience in healthcare, he's also a professor, also working on the political scene. So when we thought about who can we bring in to really bring in relevant knowledge of public policy, but has worked in this issue and is very dedicated to this community, Manny Rosa immediately came to mind. He's a longtime friend of the Latino Leadership Institute. So without further ado, let's get to the good stuff, and here we go with Manny.
So good morning, everybody. Thank you for sharing your time with me. And on behalf of my students who would normally be in class with me, I think I'm going to say thank you too, because they get the morning off, and they were kind of happy, so they get to see, for the weekend, all right? So I teach at Queens College. I have 2 courses at Queens College, just to put things in perspective. I teach a nonprofit management course, as well as a course now in New York City politics, and then another course on the delivery of public services. So I've been doing this for a little while, and I enjoy the dialogue and the conversation that I have with my students because I learn from them as well. So I get to share my experience, what little knowledge I may have with them, and then as we get to know each other during the semester, and as they become more enlightened, they pick up on things that they are seeing on the outside, they bring it into the class, and it makes the class that much better. So I'm hoping that the discussion this morning will spark some thoughts into your mind, not only with reference to healthcare, and I apologize for the typo. I was sitting here saying, I'm mortified. So institute is not spelled that way, just in case anyone wants to see that. Truth in advertising, right? But I think it's important that we kind of understand where we're at on February 22nd, 2014. And we are living, I suppose, in yet another evolution in terms of demographics, in terms of political policy, and we are also living, just in case you have forgotten, in a campaign year. These are midterm elections that are coming up in November. And again, the battle for the hearts and soul of America. But unlike 2012, when we had the presidential election, we have to keep in mind that these elections are very local. They may have national impact, but they are very local in the way the candidates approach it. So their constituencies, where they may get some money out of Washington or come here to New York to do fundraising, their constituencies are back home in the churches, in the social clubs, in the senior citizen centers, in the schools, the parents association, and their perspective, if you will, what they bring to Washington in this particular case, is going to come from them. So as we are listening to the healthcare debate, the economy debate, government too big, government too small, what can government do for you today? Always remember that as we look from today going forward into November, that what is happening is this debate at home. And we don't see that a lot here in New York. That's one of the crazy things. We are so used to our elected officials. We know who our elected officials are. They've been around as long as I have been. True story. I was an intern back in 1972. Okay? I worked for then Congressman Herman Badija. At that point, he was representing what they called the Tri-Borough District. He had parts of Queens, Manhattan, and the Bronx. So I was in college, and I was lucky enough to work in his Washington office. One day, I'm downstairs going toward the chamber, and who do I walk by but Charlie Rangel. Charlie Rangel was now going into his second term. Okay. As a representative of the House from New York. Perspective and context. I was the first district administrator for Native Alaska when she won way back in 1993, 94. So they've been around. We're talking about 30 years, 20 years, right? And in New York, they become political institutions. And we have to look at it that way, but I'm not sure that we're using them that way. And herein lies the difference. So what I want to talk about today is 2 things, right? Healthcare access, which we've been talking about ad nauseum through Obamacare and insurances and money and things like that, but healthcare delivery. What is happening in your own district, in your own neighborhood, with reference to the health care of your neighbor, yourself, your family members, etc.? How do we measure how healthy we are? Right? Now, In passing, everybody can hear me, yes? Can you hear me back there? In passing, we ask ourselves, we see each other and say, how are you feeling? My father used to taught me a lesson about wait for the answer. Because we would say, how are you feeling? And you keep on walking and the person's starting and we're not listening. Right? The healthcare system sometimes is just like that. We ask the question, how are you feeling? But we are not measuring, we're not taking account of what is happening to our neighbors, what is happening to our communities. And you'll see in a slide later on, some of the communities that we live in, our folks don't have a long length of life. When I was in the governor's office back in 1994, I went around to speak to young people because at that time one of the agencies in my portfolio was the then Division for Youth, now Children and Families. And I would ask young people a lot of questions about what they wanted to do, what they wanted to be, how they were feeling about life. And these were kids from 14 to maybe 21, 22. One of the things I used to do at the end of the conversation, because I wanted to have a dialogue with them, is to get a sense of how they were feeling about their own life and ask them how many people believe, how many people in the room believe that they would live, and I would just say, to 20, 30 years old. 20 to 30. And they would all raise their hand. They were all big, bad, and brave at that point. Then I would go 30 to 40. And now the hands are beginning to not come up. And when it got to 50 and 60, I can tell you that a good 50%, maybe more, would not raise their hand. So that when young people are not believing that they're going to have a long length of life, they may do things, we call them risky behaviors, yes, that may be detrimental to their health and the health of people around them. So sometimes we have to take the pulse of what is happening in our community. How many people in this room actually work in a healthcare setting? 1, 2, 3, 4. Okay, so you're on the front lines, yes? You see it all the time. I use that word deliberately, that term deliberately, because I was taught that when I was at HSC. You are on the front lines, in the emergency room, trying to tell a person why they can't see their doctor because the insurance card is not working, right? The benefits are not, and so a person who's coming into a medical setting, a healthcare setting, seeking our assistance, sometimes leaves sicker than when they walk in because the stress is such within the system that they don't feel welcome. So there's a difference between an access to care and a health insurance card that will get you in the door and the delivery of care that when we ask, how are you feeling, there is someone who is going to answer them and wait for the answer and then figure out what to do next. That is what we have to do in terms of framing the dialogue moving forward. And it's really important that we measure ourselves from that perspective. So I took this picture, and it's a Norman Rockwell picture. Anyone who knows Norman Rockwell knows that he was the great artist for America in simpler times. And what gives this one away is the thermometer. You see, it's not something you put on the forehead or the ear or under the armpit or whatever the case is. It's a thermometer. I'm hoping it's an oral thermometer and not the other kind. All right? But nonetheless, there's a relationship there. There's a relationship. The doctor's relationship with the patient. As simple as reading the thermometer together. So the question that I would have for you probably is, when you go to the doctor, do you feel that relationship? Okay? And part of the reason why you may not is because those of us who've been on the administrative side know, what is it? You got 15 minutes, but you got to see 5 patients in an hour because we need our money. Okay? And if you go 15 and a half, the director or the administrator of the clinic is going to say, you're not meeting your quota. You're not meeting what we need in order to make the money. Right? I don't see a time clock there. I don't see a clock there. I see patience there. Patience with a patient. Yes? Right? So the question is, in 2014, has our healthcare system evolved to such a state that's too complex for the patients that we want to serve, for the people that we want to serve, for the outcomes that we want? And as advocates and as activists, that's the accountability that we need to bring back to the policymakers. You see? So that when you go to a hospital and there's a community advisory board, if you go to a hearing and there's a member of your council, your councilmatic district, there's a member of the health committee, they need to hear from you saying, there's a disconnect somewhere along the line. There's a disconnect. And it's become too complex. When we don't know how to maneuver and manipulate the system, at the end, very frankly, we are counterproductive to what we are trying to achieve when we say to the world that we have the best healthcare system. And the outcomes and the numbers point otherwise. So, let me talk a question. Does it become too complex? Look at all the years of our lives. 2010, 2011, 2012, 2013. In fact, when I did this the first time, I forgot about 2013. I went back to 2014. And my nephew said, what happened in 2013? Right? The unending Obamacare debate. Many people are tired of debate. Raise your hand. Okay? We're tired of it, yes? It is sucking the oxygen out of the room. And yet we still, at any point, you put on the TV, go on the blog, listen to the radio, right? And it's Obamacare this, and Obamacare that, right? And we are trying to, and we make this the anachronism for either all that is wrong with government, or all that could be good about government. The man went into Washington with a single frame of mind. He wanted to do what could not be done by his predecessors. And, and we need to talk about that in context. When you go all the way back to Harry Truman, that's a president. I'm just to see if anyone was around. Okay? I just was perusing the room just in case. Okay? You go all the way back to Harry Truman, who wanted to reform healthcare back in the 1940s. And you fast forward the tape to 2009, 2010, and you can't get it done. And the closest thing that you get is a Medicare system or a Medicaid system under Lyndon Johnson. And even that is still being debated in terms of its efficacy and whether or not it costs too much, and whether or not it's a good thing to have, and whether or not there's a stigma to Medicaid, and whether or not we're serving our seniors properly through Medicare. When you look at the year, 1, 2, 3, 4, 5. So if a child was born in 2010, they're going to school 2013, 2014. Just imagine that. So in the lifetime of a little child, this debate has been going on. And that little child may grow up having to deal with the outcome of that debate. Now, I want to put something in perspective, because I tell this to my class all the time. This has also become the argument about the role of government, yes? How big should government be? How intrusive should it be? Is it too intrusive? All right? So we start, by the way, one of the arguments is that the other side would use against Obamacare is, well, we really don't have 48 million people that are uninsured. How so? Well, if you take young people who don't want health insurance, and you take, I'll use their term, which I hate, which is illegal aliens, right? Undocumented. And you take them out of that number. Now we're reducing the number all of a sudden, artificially, but we're reducing the number. And when those individuals show up into the emergency room, someone has to pay for it. Again, the front line, yes? And that someone happens to be everybody in this room. So that when we start talking about why a hospital is closing because they can't afford to stay open and what's the battle in my neighborhood to keep my clinic open and things like that, we find that the argument, if you will, is not so much is the hospital worthy of staying open, should it stay open, but can we afford to keep it open, right? So healthcare affordability becomes now the measure of keeping a clinic open or keeping a hospital open. And we're seeing this in Long Island College Hospital in Brooklyn, Interfaith in Brooklyn. We see it in Queens with St. Mary's, St. John's, and some other hospitals as well, Westchester Square and Bronx. So we have those issues. 5 years, and it's still not over. But this is not the debate about Obamacare, it's a debate about how big government should be. Let me put something else in perspective. The first $100 billion federal budget was introduced by Lyndon Johnson in 1964. Some of us were alive in 1964. $100 billion federal budget. Today we're talking about a $2 to $3 trillion federal budget in about 55 years. In our lifetime. So the debate that ensues when we try to bring in reforms stems from, not now, okay, not now, is the perspective that people keep in mind. And I need to tell you that there are folks who were around back in the 1960s that did not want Medicare and Medicaid. So this is not a new argument. Obamacare is not new. All right? The question is, all right, do we have the perseverance to see it through? And I want to go back to 2010 because that was a pivotal year in this discussion. All right? It took the Supreme Court, basically, to figure out somehow that this was a constitutional law, with the exception of one part, which is, I call the escape clause, when the Supreme Court said that states don't have to opt into the Medicaid portion. And one of the core foundations of Obamacare is the expansion of Medicaid. So if a state doesn't opt in, for whatever reason, then that expansion is not going to happen, and then the coverage obviously is limited. Now, I will share this with you from a policy perspective. And forgive me for being a little technical, but you need to understand this. How many people remember the stimulus, the Obama stimulus package? Okay, there's a lot of folks, right? So, unlike the state and the city, you don't have to have a balanced budget at the federal level. And the idea of the stimulus really was to try to put people to work, right? It was supposed to be the bridges, it was supposed to be the streets, it was supposed to be the infrastructure, all those things that basically cost the billions of dollars that it did. But it was off budget. It was not part of the regular budget. And that was a very important point. Okay. So that when the money dried up, they had to scurry to make sure that the teachers that were being paid with that money still could get paid, and the police officers still could get paid. Because what had happened at the state and local level was that rather than build the bridges and fix the highways and things like that, they moved some of that money to operating costs because they were running out of money. So governors say now, what happens when the federal dollars dry up for Medicaid and you're going to lay this burden on the states? And that's the future debate, and that's something that you have to trend out. You see, because healthcare is such a complicated issue. It is so difficult to understand. It's the financing, it's the delivery, it's the measurements, it's a whole bunch of things, right? But down the road, there is going to be a debate about this expanded Medicaid and the federal portion of it, and whether or not states are going to pick up as that money begins to be. I'm saying this now. It's February 22nd, 2014. 4 or 5 years from now, you may be hearing about this in And so you got to keep that in mind, because that becomes then, right, that becomes then one of the policy issues at the state and local level. Those of you who are going to run for office may have to deal with that if you are successful in voting for state and local dollars just to keep up the Medicaid portion of the expansion. So the debate regarding the Affordable Care Act, ACA, also known as Obamacare, seems to be focused not on patient care or health care affordability, but on power politics. It's power politics, right? So I started out saying that this is an election year. This is a midterm election. Make the connection, connect the dots for a second, all right? What happens when this is brought back to the local district? And one of the problems with Obamacare is that every time you have a misstep, every time something is not working, you press that button and the information doesn't go in the computer, right? Or someone has to pay more on the premium, or someone has lost their insurance, or they cannot manipulate the system, then the failure is pronounced a lot greater in an election year. In an election year. Maybe not so much here in New York. Okay? New York City. But go upstate. Go upstate. Go beyond the Bronx for a moment and see the rest of America, okay? Maybe not the 5 boroughs. Or, if you really want to see it, maybe go Staten Island. Right? You do have Staten Island. So, I put here left versus right and right versus left because for some people, Obama's not doing enough. Some people want universal health care, the single-payer system. Forget about all of this mumbo-jumbo with the insurance companies. Let's just go with a single-payer system. Oh, boy. Right? Can you imagine the debate then? All the right that every time they offer an alternative, the first line in that alternative is the repeal of Obamacare. The repeal, as though it never existed. Power politics. Who is stronger? More macho, right? So, we are not looking at outcomes in this debate. We're not looking at how accessible it is for our seniors or for our children. What we're looking at is my message better than your message? Is my message going to resonate more? The see, I told you so. The see, I told you so. Or what Mr. Obama has had to do, which is the rope-a-dope of Muhammad Ali, right? That every time they come at him, right, he's had to defend himself. Now, he's in the 50th year of his presidency. He will not run again. So for 5 years, you've been debating this. For 5 years, you've been trying to do other things in your agenda, and yet they don't let you off the hook. You are against those ropes because this fight is so prevalent in the room. Yes?
I think it's just another strategy
Yes.
to keep people poor and sick. I have lived abroad in Europe and Latin America. I lived in Costa Rica for a year. They don't have a military, so the money that they were to spend on the military, they use it on education and health care.
Right.
And Costa Rica, along with Cuba, and Puerto Rico, which a lot of times they don't look at our statistics because we are a territory, and Cuba, they have the highest literacy rates in Latin America. I got sick in Costa Rica, and I was not a resident. And I went to the hospital several times. I never got a bill. When I lived in Italy, I would travel all over. I got sick in different countries in Europe. I was in hospitals and I got treated. I never got a bill. So this is all just to keep people poor and sick. And the whole thing of the government not sharing the pie. This mentality of this very individualistic society, and it's all me, 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 and that's going to change.
And I don't disagree with what you're saying, right? So what happens is, to your point, okay, the world measures us, right, on how we take care of our vulnerable populations, right? Our sick and our elderly. We are viewed, right, maybe as not as sophisticated, maybe not as powerful. Maybe that's our weakness. And yet, when we changed welfare back in the 1990s, the law was called the Personal Responsibility Act, to your point. Okay? The Personal Responsibility Act. The old stories, I don't know how true they are,
When I was young, right, I worked 15 jobs in 24 hours. Right? I got up, put my pants, drank a cup of coffee, and dug 5 ditches. By the time 12 o'clock came around, I had some lunch, and I went into the mines and dug some coal. By the time dinner came around, I went to milk the cows.
Right? And so somewhere along the line, the story of working the 3 jobs and things like that became the methodology by which we started measuring the person's work. And if they could not work, did not work, and things like that, they were less than. Right? So when I saw this cartoon, it speaks to values. What are our values? Okay? So I said, and it's so funny. Mitch McConnell has a primary, or will have a primary back in Kentucky, from a person from the Tea Party from the far right. So if he's not conservative enough, okay, for parts of his political party, right, imagine what will happen if he wins, or imagine what will happen if he loses, and the message that gives out. We should not minimize what happens at that local race, where even if you're conservative, there are people to the right of you that are still challenging you for your power base. He's the minority leader in the Senate. That doesn't matter to some people. That power doesn't matter. And you have a speaker who for the longest time was held hostage, for lack of a better phrase, by members of his conference that were to his right, who did not want to see government continue, not in the way they thought it should continue. And so he was held basically powerless back in October. We can't forget that. So there's a lot of truth in these statements. They do call Obamacare socialist. West of Manhattan, north of the Bronx, right? South of New Jersey, that's a dirty word. Yes?
But I think the problem is more the unintended consequences of the law, Obamacare. For instance, right now the insurance companies has risen the insurance premiums. I personally, I've been affected with that. I'm not a rich person, but I have to pay more for my health care, for my insurance. And also what is going on with unemployment. Right now people are losing their jobs. Right now they're getting more part-time work than they should. But it's more, I think, based on the unintended consequences of the law, that we're affecting more the people that we're supposed to help, they're supposed to benefit from the law.
So what happens is, like anything in government, right? There are these rollout years where all these little things, all these big things come up, like the glitches in the computer, right? The misinterpretation of the old policy versus the new policy against the law. If you like your policy, right? The premium cost, I was looking at that as well. But again, we're talking about what is presented to you as alternatives, you see? So that we've gotten to the point where even if the law was repealed, you're not going to go back to what you may have considered, or anyone considers, the good old days. Because there's so much scrutiny of the insurance companies now that jumps in premiums under the older system would be questioned, right? The Republicans like portions of the Obamacare. They come around and like portions of it, like the children that could be on the parents' policies to 26, parts of the Medicare. So the healthcare system, for whatever it's worth, in 2014 will never go back to what it was. And I think this, what you're speaking to, is a problem that I think this president's had for his entire term, which is the governing part. Can he govern? So if you go back to the history of how this bill was put together, big bill, right? President of the United States, with all due respect, never presented his own bill to Congress. This is a conglomeration of committees and commissions and people that were put together in a room, members of Congress, members of the Senate, people from the industry and things like that, and somewhere along the line, there was a law that was put together. But even as that was being put together, they were talking about waivers, right? Who was going to be covered, who was not going to be covered, what you're going to have, and things like that. So that it was never clear whether or not this bill is exactly what President Obama intended when he first rolled out the idea. We'll never know. But clearly, he has a style, very frankly, that in some decisions, he pushes it off to some other folks, and then what happens is what you're talking about. You see? Now, since he is the President of the United States, since he is the person where all the cameras are focused on, good, bad, or indifferent, he will take the blame. Just like the mayor will take the blame for all the snow that's not clean and things like that, regardless, yes? All right? So, I'm not holding President Obama immune from criticism, all right? Because I know that this is not the most perfect rollout. And it will never be. There's always going to be these glitches that you got to go back in. Look, I remember, I worked for Jose Serrano when he was in the Assembly. He was the chairman of the Education Committee. And he put in a bill to help deal with dropout prevention. And he wanted the community-based organization to get some of that money. Here's the problem. The first year of rollout, only one organization was given the money from the Board of Education because the way the law was written. He had to go back into the Assembly and rewrite portions of the law so that that money could be spread out, and so now only one organization would get it. So chances are, all right, if he had his way, he would go back and probably tighten up some of these issues. Here's the problem. Can I get it through? Because he has a House of Representatives that's not controlled by his party, that's fundamentally opposed to Obamacare. So any changes in the law that you might have gotten if it was a Democratic-controlled House and a Democratic-controlled Senate is not going to happen. It's just not going to happen. And that's why I say keep in mind what's going to happen a few months from now in November. So, I want to get away then a little bit from this issue of just access to care. All right? Everybody have a health insurance card here? All right, or has access? All right. You have it, right? So if, God forbid, you become ill and you need to go to the hospital, you take that card, because they ask you, you may be dying, but there's going to be someone there as you're bleeding to death says, show me your insurance card, right? Am I telling the truth? All right? You could be the guy asking the question. I don't know. Right? So what happens? Right? What happens? It's not an access, it's not the issue of going to the hospital. It's what happens when you're in the hospital. It's what happens when you're in the doctor's office or in that clinic. All right? The development of healthcare policy must address the needs of our community. It's not about access to health insurance. If you look at all the public health insurance policies over the years, we have spent billions of dollars. Truth and advertise. It was Orrin Hatch who sponsored the Child Health Plus legislation in the Senate when the Republicans, when the Republicans controlled the House way back in the day. So it wasn't an issue that we're not willing to insure our children. It's not an issue that we want to insure our elderly, because Medicare has been around for a long time. It's that healthy in-between, right, that always gets into trouble. And now we're trying to address that, trying to deal with that. But it's the delivery of healthcare service that we're not paying attention to. So if I were to ask you, how healthy do you think your community is, your neighborhood, could you answer the question? Could you answer the question? Do you have the statistics, the trends, right? The information that you need to measure how healthy your community is? Chances are, unless you're in the business, unless you like this kind of stuff, or you're on some boards and things like that, the answer is no. The answer is no. How many hearings have you heard, how many articles have you read about health outcomes? Health outcomes. What we are hearing about, can we afford Obamacare in terms of the money? It's the economics of healthcare that we're debating. Right? The billions of dollars that it will cost to cover people. the billions of dollars to expand Medicaid, the billions of dollars to have prescription benefits, the billions of dollars for children, right? But we're not asking of all this money how many minorities are being trained as doctors and as healthcare professionals. And when I say we asking, I'm talking about when we go to City Hall and we see a councilman here, when we go to the state legislature and they're debating the budget as we speak, when we go to Washington and we put on C-SPAN, look at the questions that are being asked, even by our own folks. Are they asking that question? Right? They're not doing it. So it is extremely important that you start to ask the questions in the town hall. I said, look, I'm willing to go with Obamacare, I'm willing to go with expansion of Medicaid, things like that. But it'd be nice when I go into the hospital, I see some doctors, or nurses, or physician assistants, or nurse practitioners, or whoever's serving the community, that perhaps they can speak the language or understand the community that they're serving. There are two types of competencies. We know about cultural competency because that's spoken about all the time, right? When I was director of minority health, that was one of our pushes with the New York Hospital Association to start thinking about cultural competency. Now we see that in contracts and things like that. But what we're not talking about is community competency. And there lies the difference. Do you know the community you're serving? Who can you turn to if you needed to get the word out? Who would you bring into the room if you're the director of a hospital or the director of public affairs? What church would you go to? What mosque or synagogue? What community leader would you bring into the room that's not on your board right now? Right? Who's not an elected official? What business owner would you try to get involved? That's community competency. Do we know what's happening in the streets? Do we know, especially with young people, and their behaviors? And how do we address that? Right? Down the block from here is Metropolitan Hospital, Mount Sinai. Right? So we don't lack for having a hospital anywhere around here, right? And we have other institutions, not too far. That's not the symbol of our healthcare, right? It's what's happening on the outcome. So the debate has to go beyond that card that you're carrying in your wallet. And you need to bring that debate to these meetings. Why? So it says Americans are living longer, healthier lives than ever before because of social, public health, and medical technology advancements. Not every community benefits equally from these improvements, however. And I tell my class to underscore certain things, right? Not every community benefits equally from these improvements. If I go back, we spend money on medical technology. We spend public dollars on public health, right? And yet, there's a statement here that says not everybody is benefiting from that. Yes?
And what is the moral economy?
I'm sorry.
What is the moral economy when we discuss this issue of healthcare for the underprivileged?
It's, when you say the moral economy, meaning raising consciousness?
Raising consciousness,
Yes.
and as well, like,
the 1960s term, by the way. Huh? Yes, it's important that we raise that consciousness, right?
Yeah.
So let me go back to the point I was trying to make there for a second, all right? Because you're right. It's a moral issue, yes. I agree with you. But understand that in that first line, there's dollar signs. There are dollar signs in there. They're hidden. It's in between the lines. If I were to say Americans are living longer, healthier lives than ever before because of social, public health expenditures in the billions of dollars, right?
Is it social or is it private?
No, it's government funding. Look at how much money we've spent. I said, I don't know if you were here. You go from $100 billion in government expenditures in 1964 to $2 to $3 trillion 50 years later. Somewhere along the line, we're spending money on public health policy. We have offices of public health insurance, yeah, at City Hall. And yet not every community benefits. Persistent and well documented. See, this is the thing. Persistent, it's ongoing over and over and over and over again. So, how many people have children here? Right? Ever driven in the car with a young kid? Right? And you hear this question, how Are we there yet? Do not say that. Are we there yet? Right? And by the time you get to your destination, you're so frazzled from that same question, right? But we're not asking the question if it's well documented. We're not asking them, are we there yet? See, we're not asking the policymakers, are we there yet? So that statement should be past tense, but it's present tense. There's the problem. So you as public activists, future candidates, people in the community need to understand that when a statement like this is being brought up, and by the way, national conference of state legislators, elected officials, yes? They should be asking the question too. Right? Know that there are dollar signs there. Persistent and well-documented health disparities exist between various racial and ethnic populations, even when accounting for economic status. So it doesn't necessarily mean money. Good old racial prejudice and bigotry. Yes?
I think I work as a volunteer breastfeeding counselor and medical interpreter at Metropolitan Hospital, and I used to be a teacher for a long time. I taught for almost 25 years, and I work as a breastfeeding counselor and medical interpreter. And I see the greatest link is health literacy, because a person's greatest predictor of health is their educational level and their reading level as well. We have high rates of college dropouts in the United States with Latinos, and also we have immigrants that are coming with very low grade levels. And then we have, and this is very strong, the language issue. So when I work as a medical interpreter, and the doctor uses, the healthcare provider uses the word hypertension, hello, they're not going to understand that. So I'm not supposed to lower the register, but I do, even though I'm not supposed to. So I give them the fancy word in Spanish, hipertensión, and then I have to bring the register down and say presión alta, because otherwise it's going to go back and forth, and the provider's going to get annoyed, and the patient is going to get annoyed too.
I can say that brings to the question of what are we expected to do with the undocumented population in the United States if we can't extend public health insurance to some adults in the community?
So that's, it's like you guys have seen my presentation, right? So I can try to cover that a little later down the road. One of the issues that we are constantly speaking about, and this is the tug of war, the house, right? On the one hand, there is a large number of undocumented immigrants, right, who, because of the law, as it is written now, cannot get long-term health care. You can get emergency health care, but not for any chronic disease and things like that. So the outcome for that, obviously, is that the illnesses that are treatable and in some cases avoid hospitalization become so acute that unfortunately we're hospitalizing them through the emergency. And that's how we're paying for it. You see, the emergency room becomes the doctor. We haven't gotten over the debate about what to do on immigration to begin with, to answer the question that you're raising, because again, it is the role of government, it is the rule of law, and all the arguments that you are hearing, that you're constantly hearing, in the face of the immigration debate, but you're raising far more than an immigration debate. You're talking about a human being and their well-being. And we haven't gotten to that level yet, unfortunately. Not in the circles of policy. So look at the people that are represented. Look at people that should be raising that issue. Okay? Look at, right, even with children. And we have in this state presumptive eligibility for children in our Medicaid program, our child health care program. So we don't ask those questions. But that's not to be said for Mississippi, Texas, or other states where there are, Texas especially, where you have high levels of immigration, and they can't access the healthcare system. Yes?
The thing about this debate, or this so-called debate that we have with healthcare, happens with a lot of issues, but especially with healthcare, the problem is that sometimes it's not a genuine debate. You may be debating somebody that has a fundamental different view of what is right and wrong, or the way the universe and life should be. I work with somebody who is, leans more towards the Tea Party, And so we'll go back and forth talking about healthcare. And then one day he tells me, oh, well, you know, I don't really see healthcare as a right. There's whatever percentage of the countries around the world that don't have healthcare, and that's fine. And you see people in Haiti all the time. He actually said this. People in Haiti don't have healthcare, and they're fine. And I'm like, no, they're not fine. But we can't even have a debate about the premiums going up and about the emergency room and all this, because that fundamental way of thinking is just totally, it's from another world.
And I agree with you. So let me put this in baseball terms. Forgive me for my sports analogy. You have America is like a baseball season, right? It's 162 games, right? You're going to win 60 games, and you're going to lose 60 games, right? The right and the left, right? So somewhere along the line, you have to convince the people in the middle. You have to somehow win the majority of those 42 games in order to get to the level that you're talking about. Okay, that's where the dialogue has to begin. In New York City, okay, we have been celebrating through Mr. de Blasio's election, right, the resurgence of the progressive movement, right? And so New York proudly states that it is the center of the progressive movement. If you go to Texas, or if you go to the Deep South, right, they're in love with their Tea Party. Utah and other states, just as much as we may be in love with our progressive movement. But there are business leaders, and there are government leaders, and there are other people who may not be to the left or to the right. And so those are the folks that somewhere along the line this dialogue has to, in terms of immigration, in terms of what is the right thing to do, in terms of teaching, in terms of what we call investments, right? Look at the terms that we are using now, whenever you read, if you will, budget messages, right? We don't say we're spending $58 billion on Medicaid, right? We are investing $58 billion in public health insurance policies. More private and more manageable and nicer, yes? Especially for those who are criticizing such expenditures. We're going to change the language because people come to understand that somewhere along the line you cannot stay stuck in the 1960s or in that same lesson. You just can't. You have to change that. Right? So look at what happens here. What happens with health disparities. I'll be with you guys in 2 seconds. This is the reality of what we need to face and speak about. All right? When I was director of minority health, one of the interesting things that I would go around the state and I would speak to people and notice among minorities the lack of screening for cancers, for example. Especially prostate cancer and breast cancer and cervical cancer, those 3 cancers. It was absolutely incredible. Here, America, and the Cancer Society and science is making these tremendous leaps and bounds in technology and in science, and yet our mortality rates as a result of not getting the pre-screening and not taking care of it because we have to go work, right? Because we don't have the health insurance, because we don't have the literature, because we are undocumented, whatever reason, right? We're dying off faster. So that these statistics, if you will, are not surprising to anyone in this room, but are a reminder, yet again, not of health disparities, but the lack of outcomes for the investments that I was just talking about, and that it makes real, if you will, the previous slide, when it says not everybody is benefiting from these modern technologies. So your tax dollars, with all due respect, is just as valuable as the tax dollars for someone who may be at a higher income rate. And so you should be demanding the same thing from your elected officials in terms of accountability for the quote-unquote investments in your neighborhood. In your neighborhood. This is your neighborhood. This is not somewhere. See, the one of the things that we teach a lot of times is the we, the me, the we, the them. Me. How does it impact me? So when it impacts me, boy, we're all interested, right? We all go crazy, right? Christmas time. What did you get me? Right? What is my present? My birthday, right? It's my birthday. National holiday, right? My wife, my anniversary. Not our anniversary, my anniversary, right? Okay. Then it's the we, right? Our community. Do we have enough sense to be aware of what's happening in our community? How does it affect us? But then there are some that say that's their problem. That's them. So let me bring this to another story. I like to tell stories. And it goes back to why there was a war on poverty all of a sudden. There was always a them. There was always a them poor folks, them minorities, them colored folks, whatever the case may be, right? That's back in the day. Less than value. Then all of a sudden, CBS TV puts out a special story about poverty. But this wasn't poverty in El Barrio. It wasn't poverty downtown Detroit. It was poverty in the Appalachian Mountains. And as Gomer Pyle would say, surprise, surprise, surprise. You mean there are poor white folk in this country? We got to do something about that. Okay? True story. Okay? You need to see it, right, in order to act. So what happens is that, as I said, we're not surprised about this, and I could tell you so, you know. When someone is unemployed, welcome to my world. I've been poor all my life, right? So that's, okay? But these statistics, if you will, cannot be a them in the discussion of what we are looking for when we are creating public health policy. Okay? We should not tolerate as a community, right, the healthcare disparities that have been taken as part of, for granted as part of the system. Because these statistics, any one of them could be a member of your family, you see. And that's the problem with not raising your consciousness, the consciousness of other people that are in power. So then I saw this. I'm going to let you read it for a second. Okay. The subway line here in New York. Yes?
I wanted to sort of go back to something you said earlier about the messaging.
Mm-hmm.
It's transferred from spending to investing.
Yes.
And if you go back one slide, there's a lot of the
Excuse me
message.
one second. This one?
Yeah, the message literally switched in terms of that second line, and probably had a lot to do with the development of the Gardasil vaccine and
Yes.
so on. So the question that I'm chasing after is how much could we do with the messaging around all of this, so that, because I feel like some of the problem has to do with the extreme right and all of the people that we're fighting against, feeling like we're trying to legislate morality in terms of the ACA.
So it's a matter of economics, yes? So let's talk about comfort zones. And I don't know how many of you in this room have been part of the lobbying effort, lobbying day, going to Albany, going to City Hall, going to Washington, going to great treats, right? I used to work in the legislature every Tuesday, boy, those buses would come in, right? And one day I was in my office and lo and behold, my aunt even shows up. And I didn't know she was coming. I said, okay, this is it, boy, right? We tend to be, we are willing to go to Washington, we're willing to go to Albany, okay? But taking the subway down to City Hall, or going around the block to the district office, or going to a town hall meeting, or even showing up in a district that may not be as friendly, going back to your point, right, to our message, right? We don't do that. Not as a concerted effort. Advocacy is hard work and it's dedicated work. Because to the degree that you need to confront the person that is opposite your position, is the degree that we start not only the dialogue and the raising of the consciousness, but making this more reality to them. You understand? So then we'll bring it to their house. When I was at HAC, the Health and Hospital Corporation, I had friends who obviously were fighting the Giuliani plan to privatize the hospital. And I would tell them, having worked in the legislature, that you cannot go to your friends all the time. You need to go to people who disagree with you and try to convince them that your argument has some validity. You may not win the day, but sometimes it's planting that seed. If not with the principal, with some of the staff members. I always say, and if anyone who does, henceforth, moving forward, if you do lobby, can I borrow this for a second? No, just. This is your position paper, right? I'm giving it to the elected official, right? Now watch, give me one second. Then she gives it to her chief of staff. Who gives it then to another staff member. Now, you following the paper? Who are you to speak to the day after? Right? The person who ended up with this piece of paper, right? To remind them that not only were you in the office, but this is a live issue. But we don't do that. Gotta follow the paper. It's really, really important. And you have to get out of your comfort zone in order for this to have any meaning to someone else. Yes?
I wanted to say, like, in reference to the example that you put up, in reference to constituents
Yes.
Going to City Hall, going to Washington. One thing that I want to bring up, because I'm looking at this, and this is like unacceptable. And the one thing that I feel all of us need to understand is that when it comes to marketing and advertising, right? These elected officials, especially the local ones, the city council people, if you're not a triple prime voter, they're not sending you anything.
Absolutely.
They're not sending you lit, they're not sending you anything. So my thing is, you know, what are we going to do as people in this class to make sure that we can go out and get the messaging out? Because obviously if we're relying on these elected officials to get the messaging to us, it's not going to come.
So one of the things that I ask my students all the time is, do you know who your elected official is? Even that level. Okay? Even that level. Do you know that they serve on committees? You know what committees they serve on? I mean, it's almost fundamental civics that we don't really engage in. Not to people in this room, and I would say that with respect. Not so much to people. You are here on a Saturday, as opposed to being in your beds or doing shopping or whatever the case may be, because you're interested in the process and in the subject matter, whatever the case may be. It's what happens when we leave here at 12 or 12:30, whatever the case may be. And then what is it that we do to take, so each one of you, to double and triple what we are talking about today, so that it's not necessarily a movement, but it's a plan of action. There's a difference between a movement and a plan of action. Right? The plan of action is what is consistent and what needs to be done day in and day out because you follow it. The movement is take that placard, go in front of City Hall, and you stand there, they take the picture, you look good for the 6 o'clock news, you look good for Eliade, whatever the case may be, I did my job, that's it. And nothing changes. You see, it's the accountability factor. This, when I saw this, struck me. Okay? This is the stops along the 4 or 5 line. The larger the circle, right, the less likely you are to live in that community to age 75. It says here in very small print, premature death is defined as dying before 75 years of age. This is, yes, representative. Okay? Will not live to age 75.
The larger one?
The larger
I
ones.
don't know, 125th.
You can even be larger, right?
It's 125th, it should be purple.
Okay. And these are statistics that come from the Department of Health. Okay? Thanks. No, but that's the point. You see? You just made the point for me. Right? When is the truth not the truth? Right? Okay? When is reality not reality? So it is incumbent upon you that to say, look, I just was in the class, I just happened to see a statistic, and from my experience, I don't have all the statistics, I don't have the scientific proof, but from my experience, you know, I know that when I moved into this neighborhood and I was younger, right? I had a whole bunch of friends. I can't tell you how many funerals I've gone to of my friends who are much younger than I am. Part of this is the number of young people that are dying in our neighborhoods as well. Youth violence, crime and things like that. All right, it's not just natural deaths from heart attack and cancer rates and things like that. We have to keep that in mind. So that the health crises in these neighborhoods along the way. If you rename the subway, right, then this is becomes a line to death. Yes? Can't do that. This is the reality that we face on a daily basis. This is not Obamacare. All right? This is not Obamacare. This is not the argument in the halls of Congress. Right? They don't even know this in the halls of Congress. Oh, well, we're hoping, yes, but we're hoping, but we gotta see what happens. Yes.
I'll take,
That's from DOH.
like in my neighborhood, for example,
Yes.
one of the things that really annoys me is that in your 4-block radius, there are 4 Kennedy Fried Chicken locations. I mean, some of our neighborhoods are so saturated
Yes.
with these types of businesses, and I understand that these businesses play to the economics of our neighborhoods. I mean, you can go with $5 out of Kennedy Fried Chicken, and you can probably feed a whole family, and so the money goes a long way. Do you think that the city can really start looking at some of these neighborhoods and maybe, I understand we live in America, I understand everybody has the access to opening up a business, but when enough is enough already, I mean, shouldn't the city start taking some type of position to start curbing these businesses? Because, I mean, I walk out of my neighborhood and I see folks on walkers and on motorized wheelchairs, people in their 50s. I mean, it's incredible.
So what happens is, of course, in a capitalist country like ours, right, we have choice. Yes? For what? To stop Kentucky Fried Chicken from opening up? No, I see the point that I think he's making, and the point that maybe one day you can make, is not so much that we stop someone from opening up. Is that we invite the alternatives to come into our community, and that it's a good business investment. You see? It's a good business investment for me to open up a Kentucky Fried Chicken or a Kennedy Fried Chicken in my neighborhood, because I know, as you just said, I'm going to make money of it. If I open up an organic shop, right? So part of this is, now, this is intergenerational, okay? So that younger people, with all due respect, can lead the way here, because they do have the access to better nutrition and then the more we get educated. So some of that money that you're talking about, right?
So, I mean, the ordinance is cost neutral at the front, right? Because the funding is what incentivizes greener products.
Yeah, if you get like the greenhouse and things like that, yes. If you, it's like what we're trying to do with Long Island College Hospital. We'll give greater weight to your proposal if you bring in the natural food store or whatever. I understand what you're saying. Yes.
I mean, but very much like you said in the beginning, where, I mean, we talk about, again, the conversation is driven by economics, right? Not even necessarily policy or whatever it may be, because we talk about, I mean, in this neighborhood, for example, is perfect, right? There's not a lot of healthy food options, but when you talk about healthy food options and you look at then what this neighborhood is made up economically, right, in terms of household income, they can't afford the healthy options, right? Even, I mean, and we talk about ordinance, I mean, and I think that's the piece where, where does then this conversation shift? Where is it a cultural conversation where we're shifting, right, the perception of how people look at their neighborhoods and say, well, I'm now, like you said, demanding more because my tax dollars need to be X, Y, and Z? Or do we say, how do we limit businesses or educate? I mean, and again, that's the piece for me. It's like there's all these different components, and but again, I think where America comes down to the book.
Right. So the challenge is basically a menu of what's in front of you, right? Not only the choices, but what is it that we as the consumer, right? We as the community are asking in terms of investments. So let's go back to if there's a tax break, let's say, for stores that open up and green stores, the fruit markets and things like that, where fresh produce is, maybe that's the way to go, all right? Spending some of this money on the public health education that we were talking about before. but not just in literature, but once in a while seeing something on the TV or on the internet, things like that, where there is mass marketing. I think he used the word before about marketing, right? And branding, putting a brand to good health. That we should not necessarily equate, if you will, our neighborhood with bad health outcomes. All right? Because then not only are we devaluating, very frankly, but then we are accepting less than. So the issue then is how imaginative and how much do we think out of the box? That's the purpose of discussions like this. That you take this out, if you will, right? And when I keep on talking about town halls and meetings and things, even small meetings, because there is a lot of money. Banks have to be invested in communities, right? There's the tax policies that she's talking about. There's the education policies that we're talking about. Some of it is plain old, unfortunate illiteracy. We don't have the knowledge. So what do we do to encourage that? Sometimes it's subtle. You know, when we were younger, most they used to go home, right? You know, from the teacher to the parent and things like that, where there were messages about whatever the case may be, the event or whatever in school. Sometimes that has to happen. But we have to be in control, if you will, of the message as well. So that it means we have to be in the room, we have to be talking to one another, we have to be talking to experts, we have to be willing to make the coalitions and the networks necessary to make that happen. And it can't be isolated. That's the mistake. Yes? Yes?
I don't know if it's exclusive only in where I work.
Uh-huh. Where do you work?
Okay.
Where do you
I don't know
work?
if it's exclusive only where I work, but another portion of what we're talking about here is, and maybe you can help me understand this monster.
Uh-huh.
And that is that when you have coverage, then you have to understand, which the literacy part comes into, that is so very important. The part where you go to a doctor, and if you don't understand the concept of in-network and out-of-network and so forth, and with all the changes that are taking place, and even people that will be changing from one coverage to the other, and when I understand the work that it takes alone, you go to an in-network doctor or out-of-network doctor, the doctor's not in-network, now you pay the out-of-pocket expense, the minimum out-of-pocket expense, you fill out this form to get the reimbursement minimum, now you have a balance that you have to pay out of your pocket. So it's more.
So it becomes
It's a lot more.
right?
I'm sorry?
It becomes a disincentive, if you will, to
It's
access
a
your
monster.
healthcare. Yes,
It's
absolutely.
horrible. Again,
Right.
when people can't even afford to pay for this medical insurance coverage, you know, from their pocket, now they have to
Someone
deal
else
with
said
the
that.
out-of-pocket expense
Right.
because they made a mistake and not research and read where they can't. It's really out of
So
control.
I asked a question at the beginning of the presentation, and I said, has the healthcare system become too complex, right, for the people it is meant to serve? There is a resounding yes to that question, right? That's the answer, yes, because of all the things you're talking about, the bureaucracies and whatever. The problem is, very frankly, what are we willing to spend our money? I'm going to say spend, not so much invest. Okay? So that, again, hindsight is 20/20. Mr. Obama failed to educate, right, the country on what the system is going to be once it is fully in place. It was very haphazard. We depended on other people, the state, right? So that questions as technical as yours, in network, out of network, right? Fees, out-of-pocket expenses, co-pays, what is covered, what is not covered, all right, is what creates the barriers to care, right? Again, the economics. Someone had that, yes.
All right. Okay, so we're looking at Affordable Care Act.
Okay.
Does that mean that there's going to be a dilution of the quality of health care that
Well,
Americans
that's the
are
question
gonna
I'm
get?
asking. Okay, so that's the question that I've been trying to bring up.
So is it going to be mediocre care?
Well, the question is, what do we have now?
Okay. And the second part of the question is, what does that do as far as the jobs in the healthcare industry?
Right. We know that one of the sectors that's been growing faster than any sector is the healthcare industry by far, okay? But the question is, what type of jobs are there? Okay, what type of jobs are needed? If I were to come into this room, I always use the, if I come from Mars and I walk into this room, what I'm hearing is I need community educators, right? I need people who are going to provide quality care. I'm going to need people to explain my premiums and understand the insurance bureaucracies and policies. I'm going to need people to speak my language. I'm going to need people to measure, if you will, the quality of care in my neighborhood, right? The problem is, and this is always, again, a public policy issue, right? The issue of evaluation. How much money are we willing to spend to evaluate the system? And by the way, a lot of programs don't have money for evaluation. You know who does the evaluation? Foundations, colleges, newspapers. They're the ones seemingly that are measuring outcomes instead of some of the departments. Now, the Department of Health is trying to reverse that a little bit, but they do so by holding the providers accountable for reporting, and then they'll start to measure. But the objective measurements that you're talking about, to say, is this quality care, is this not quality care, that's not being done. You got a question? Yes?
Yeah, what I have been hearing from the crowd here during the last 2 Saturdays
Yes.
and today, and from the presenter, is there is a fundamental issue relating to the effectiveness of advocacy and activism.
Right.
And this is not really the lack of access to information or awareness. We're out to the awareness level. But who distribute what kind of information at the community level? And how much time is given to communication? I'm a communication specialist. I have been through many, many countries. And we deal with grassroots, from mothers to families to children. We don't leave it just to one person or activist or group. You have to go through this. Now, there is really no communication, there is really no appropriate monitoring of the moral or ethical or balanced implication of any message that is brought out there. And this is especially true to an open society, because we're always looking at how much will we put as to invest in personally, in our personal progress or whatever. So you do not have any kind of measurement of the development or change that you are trying to initiate.
So let me just step in here for a second.
But
I think you make a lot of points.
Well, I think I would like also to relate this to the issue of gentrification in a community, especially in an advanced or developed society. Here, I have noticed that gentrification is good. It starts with community activism and everything else. It is positive, but it does not end up as positive gentrification after all, because you have the private sector, you have progress, you have other things that combine there, and the activism and the advocacy group gets sucked in there. And so
for fear of stepping on another class or starting a war in here, let me get to, I think, a fundamental issue about advocacy, all right? So the question is, who controls the message?
The people.
Well, that's an interesting point, right? If I am an insurance company and I'm spending a lot of money on trying to persuade or to give the perception that I'm a good guy, no matter what you're reading in the newspapers, right? It's image making, right? I'm trying to build my brand. We are at a disadvantage in terms of monetary resources, but not, as you say, human resource or even access to information. It is amazing how many people have smartphones in our community, right? And we measure the smartness of how fast you can win a game, right? As opposed to accessing the information you have. One of the big differences, I keep on going back to the mid-60s, for example, and the 50s, about, and you made a good point about communication, is that the excuse, if you will, for the lack of communication really shouldn't exist anymore, all right? It is, for lack of a better phrase, the necessity of doing homework, right? You need to do your homework. So let me go back to the point I was making with reference to individuals that advocate only with their friends, right? You need to understand what the opposition is saying and need to give sometimes the validity of some of their arguments. They're not all wrong. When I worked at HXC, Dr. Marcos used to say, he was the president of the corporation, he said, we're not as bad as they say, nor as good as we say, right? The truth lies in the middle somewhere along the line. And we should not be persuaded by our own arguments. We're the ones who are making it. So the issue is doing the homework. And I liken this as the onion. Someone told me the thing of the onion, right? That you peel enough layers, that you ask enough questions so that you get to the core of the issue, right? That one thing leads to the other. If I spend $100 billion on a public insurance policy, Medicare, for argument's sake, what do I get for that? You get better health outcomes. That's the point. See, I'm just going to go by the layers, right? How do we define it? How are we defining the argument? So that the issue of advocacy and communication is the amount of information that you arm yourself with prior to going into the room. And we don't do that, either because we don't have the homework, we don't know how to do it, or we don't discuss it as we should. We're not versed in that. But we don't have the excuse of not having access to that. Because when I had hair, and I was a little boy, right? It was Channel 2, Channel 4, Channel 5, Channel 9, Channel 13, right? Channel 7. 41 and 47. Happy day when 41 and 47 came out in 31, okay? Now you have 200, 300 channels on cable. And you have the internet, and you have everything else. So the issue here is not limited information, right? It's that you limit yourself to the information, and that's the barrier sometimes. Yes?
Yeah, I wanted to make a point about something that was mentioned here regarding food deserts. And this actually, a lot of research has been done recently about food deserts. And I don't know if some of you guys know, but Michael Bloomberg actually had an initiative where he provided incentives to supermarket to provide better food options in food deserts in neighborhoods like High Ridge and Morrisania in the Bronx. Some of this research has shown that there isn't having supermarkets that would have better food options in the neighborhood doesn't necessarily, having better access in the neighborhood to healthier food options doesn't necessarily mean that people are going to buy it. And I think there are multiple factors here at play. One, from doing research myself in the field and from reading the literature, I realized that a lot of, not just in health, but a lot of the issues that we try to understand here also come down not just to systemic issues, but to human behavior. And I think that we need to see that from that perspective as well. People make choices themselves that affect their health. People make choices about their education. People make choices, different kinds of choices. And it's not necessarily based on whether they have access or not. And maybe it is because they have a predisposed opinion or whatever you may have. And also there are factors about like how much disposable income a family have. But then there's also like a very cultural issue. For instance, we have a lot of immigrants from Africa, from the Caribbean, and in the Bronx, from the Dominican Republic, Puerto Rico, from those countries. So, you know, they come in with established things that they eat, the diets that they come from and that they learn at their homes and that comes from that's cultural. So how do you say to a family, how do you say to a mom, oh, don't give your child arroz y habichuela, because that's un sal, porque un sazón, because
Too many carbs.
not if you have a lot of sazón in it. I like my sazón.
I guess the point that I'm trying to make here, is that we also have to look at the individual factors in a lot of these social problems. And there is and I recognize that there is a systemic issue. There's a problem of educating people. But yeah, there is the internet. You can educate yourself. You can find the information that you need in order to better have a better diet, etc.
But information, so let me say, before I start another water, let me step back for a second. Goes to communication, advocacy, and obviously we're touching on everything. But part of this is that information in an isolated form is no information at all. So that it needs to be vetted in such a way that there is a discussion that takes place about perception and reality. The perception and the reality. We live, unfortunately, good, bad, and different in a microwave world.
But you assume that the people will only look for information that will sort of like rectify the point that,
right. So the point I'm trying to make, and not necessarily to debate it necessarily, but the point I'm trying to make is the following. That we need to go beyond those comfort zones that we're talking about, right? All right. So we live in a microwave age, right? If it takes more than 30 seconds to get an answer, to get the computer started and getting the internet and the site that you want, you're going to turn it off. You get turned off. People who are steadfast, right, who are persistent, know that it takes more than 30 seconds. It takes more than one argument. And you need to look at different things, even in your own research. So, when I came here this morning, for example, I'm not saying that Manny Rosa has the answer to the healthcare system or its fault. What I want to, the takeaway I'm hoping that you get out of it is that you look at it differently. Okay? That it is no longer just the matter of an insurance card or federal or state or city expenditures on Medicare, Medicaid, or expanding Medicaid, or government is too big, or government is too small. But things that say, very frankly, what do we do with language? What do we do with immigration? What do we do with the reality of our neighborhoods when statistics say one thing and maybe I know different? And how do I get that message across? I need to ask a question. It's about 11:45. 11:38. So I don't know.
We finish at 12, but maybe you want to take some questions.
More questions before we take? Yeah, I just want to finish the business. So that's up to you. All right. So let me just get it because I know my students when they go, I got to answer. I got to get the question.
I just want to say this to the gentleman that mentioned the Kentucky Fried Chicken.
Yes.
An issue, like it's an issue in my community. It's the same setup, Chinese food store, liquor store, restaurant. We all want better choices. But the question that we need to ask ourselves is, all right, so if a better choice came, like a salad store or something like that, what's the point of even having that if they're not investing back in the community? And the key question here, and the key thing that I want to bring up, because my dad delivered newspapers for 20 years in Howard Beach, New York Times, John Gotti's house. And if anybody knows John Gotti, he basically told all the stores in the neighborhood, hey, listen, we have this barbecue every July 4th, and you guys are going to invest into this particular barbecue. And if you don't, there's going to be consequences. We don't leverage these stores in our communities. They come in, they do their business, and they can care less about what's going on. You go to Long Island, for example, they have booster clubs. You go into these particular stores and restaurants, and they have pictures of the teams and how much money they give the teams. We don't have that in our neighborhood, and we need to start leveraging that.
I understand. So the next mayor of the city of New York is someone that... All right, so let me get to this. Right? So one of the things that, in terms of delivery of care, is having some place to go. A doctor that you're familiar with, or a clinic that you're familiar with that you have confidence in. Chances are, if you don't have insurance, if you're an immigrant, right, if you don't understand the system, you don't have it. So that you don't have the term in the business, right, the lexicon, continuity of care. Right? So if I go to my doctor, I have a very thick, because I've been going there for years. But if I keep on going to a clinic, and one doctor sees me this week, and another doctor sees me next week, and there's no continuity of care, chances are you're going to have poor health outcomes. So when they talk about a usual source of care, it's just that having an anchor, physician, as opposed to the emergency room, that is going to monitor and partner with you, and I want to use that term, partner with you and your family and your neighbors in terms of what is happening with care. It's a very important term. Healthcare is not this way to you. It's got to be both ways, right? So we're notoriously bad. You open up a medicine cabinet in our homes, right? And the prescription says take for 7 days. We feel good after 2 days. That's the end of that medication. We don't take it. So you have a half-filled bottle of antibiotics, for example, whatever the case may be. It's health education. So the usual source of care becomes very important in terms of outcomes. And that's why when we talk about investments in public health, the training of doctors and the clinics and medical personnel, people, qualified health professionals, becomes very, very important into what is happening with our neighborhoods. It shouldn't be Metropolitan's emergency room or the outpatient clinic. It needs to be some doctors that we know, okay, that we know, and that they are comfortable with. They either speak the language or they understand the culture, how we take our medicine, how we access care, right? Now, with all due respect to everybody who's young here, you're not going to be young forever. I'm learning that lesson now. Okay? All right? But yes, okay? I'm learning that lesson the hard way, I guess, right? Especially with this winter. But look at the bottom, where it says the most dramatic change will occur with Hispanics. You have the elderly population, 2.9 million now. And for some of you, you will see 17.5 million in less, right, than 40 years. In fact, 36 years. Look at the rate of growth. If you are a public policy wonk, if you're going to look at the debate of public policy, then I would ask you a question here. Because some of us like to go to botanicas to figure out the future, right? When the future is staring you in the face. This statistic is your future for anyone who's young. I have 2 colleagues, you, right? Young. In 36 years, one of 2 things are going to happen. Okay? Either we're going to spend a lot more money on the elderly. We better pray and hope that the modern technology and science catches up to those ages, right? Or we're going to have a debate of whether or not how long someone should live if they have terminal illness or any kind of illness. Yes?
Well, also the them becomes the we.
That's exactly. Oh, thank you.
And the shift in the value on the body.
Give her A, please. All right?
Well, no, the big issue
Yes.
behind all this
Yes.
debate is the value of the bodies of people of color and of poor people. Do they deserve a quality of life that's been afforded to white people and wealthy people forever?
And part of that's our culture,
shifts
yes?
with this.
Part of that is our culture. So the question is, will you, I may not be around, but will you take your grandfather and your grandmother, right, and St. James Nursing Home, you have a bed, or are they going to be with you as is our culture, and then, you know, you take care of them as it gets more difficult? Okay? You had a question.
Yeah, and it's not really a question,
Okay,
but yeah,
statement.
it's both. It's
Okay.
a comment and a question. I sit at a board, at a community advisory board in a hospital.
Which one?
Mount Sinai, that I just joined. And I was talking to one of the doctors, and he was very engaged in the community, and he was saying about this new health Obamacare that he calls it, and he's not happy with it because he's saying that it's the cost has been coming down to paying back the doctors, which is why a lot of hospitals, you know, and one of the things is that I didn't hear in this whole Well, now I'm seeing it, that you're putting it up, but it's the
Because you
communication.
didn't let me.
No, I guess because everybody else is just going off on other issues.
Okay.
But
So,
the
yes.
main thing here is that a lot of doctors are saying is just that how they're being,
Yes,
the cost is cutting down on paying them back, and the insurance, where he said is about $1,000 for surgery, they're getting $15 out of that. And so, looking at that whole cost disparity, it really becomes a business. You know,
Yes, and that's, you make a very good point.
right, and so my thing is that when we're doing one of these, whether it's a forum or a lesson to be learned, we should bring one of these doctors here and let them speak, you know, and so this way we know exactly how, instead of just bringing it to the elected officials, bring them also so they can listen to what they're saying, because they're the ones that we're going to. Well, at least I'm into home remedies, which is why I go to the Botanica. Not to get my future, but to get my own plans so I know what to do. Home remedies, you know? But I'm just saying that we should also have the doctors come here, because it's not just about the insurance companies, but it's because the doctors are also rejecting to provide these services, and the hospitals as well.
So let's go to your point, okay, because I was about to get into reimbursement.
Okay.
All right, before you made my point for me, so everybody, thank you very much. All right, now, 17 hospitals closed in 11 years. Okay? 17 hospitals. That's more than one hospital per year. All right? We're not replacing these hospitals. What they get replaced with is maybe an urgent center, an urgent care center, maybe a clinic that's open from, 8 to 4, 8 to 5, right? And then the emergency rooms take over. So the distribution of care, obviously, is shifting in our neighborhoods. Part of that is the reimbursement rates. I gotta share something with you. Way back in the day, you're going to be hating me by the time you finish here, all these stories, right?
Well, you told the story.
All right, so way back in the day, Medicaid was not the most popular of insurance products. There was a stigma. Oh, that's poor folk insurance, right? You got Medicaid? You got Medicaid, man. How poor are you? Right? and your family. Now, you see that? Now, 2014, give me that Medicaid because it's the best payer going, right? The problem is that as any insurance policy, you're going to negotiate rates. And we believe sometimes that we have an open faucet for healthcare expenditures. And one of the things that Governor Cuomo tried to do with his redesign of Medicaid is to somehow cut the rate of growth in the expenditures. And the way that's done, more often than not, is by limiting, if you will, the rate of growth in reimbursements. And what you have then is a situation where it's almost a domino effect. So that we're not surprised that 17 hospitals are closing down and others are in financial crisis, right? But rather, we don't have the balance. And part of this is, again, a public health issue. Preventive care versus the acute care. So it's going to cost a lot more money for someone to go into an emergency room or to have a 2 or 3 day stay in Mount Sinai. You know how much you all charge, right? So then what happens is that if something happens to any hospital around you, you're going to take those folks. And then you have a large number of uninsured. And then it gets even worse. And the crisis becomes more acute. So that becomes difficult for the system to handle. Yes?
Is hospital closings, is this similar across the country? I mean, I don't know the numbers like this, so I'm wondering.
They have less hospitals across the country, so what happens is you don't have as many public hospitals, or you don't have as many.
So I guess, well, how does healthcare is a booming industry, right, where it's growing, but you have hospital closings?
Because, again, it's reimbursement rates, because of what she said before, it is a business, very frankly, because hard costs go up. An OBGYN will spend $80,000 a year on malpractice insurance. $80,000 a year, all right? The cost, because we are such a litigious society, right, where oh, you put the Band-Aid on the wrong finger, I'm suing you, right? I almost bled to death. See? Right? So right? I'm suing you, right? And so these are hard costs. Insurance premiums go up every single year. Malpractice goes up every year. The light goes up every year. The cost of equipment goes every year. Oh, you don't have an MRI? I'm going to the hospital across the street that has an MRI. You don't have a CAT scan? Because you have old-fashioned equipment. I want to go to the modern hospital, right? So that becomes very difficult to sustain, if you will, those costs quickly, right? So again, one trend is on, now look, you're going to have other closures, right? And on top of that, there's public policy that says, let's look at how many hospitalizations could have been prevented. Let's start looking at that. How many asthma attacks, how many reoccurrences, right? Diabetes and things like that, that are manageable diseases. This again calls, the lexicon, right, is the sustainability of the chronic care, right? Managing care. And it's important that you understand that if the state is looking to reduce that number, it's because they want to reduce their expenditures on the Medicaid and then other expenditures that they may have. So this is as much about the economics and the budgeting of healthcare as anything else. Yes?
I just wanted your thought really quickly on creating some type of like universal price scale. So like for example, you go to Mount Sinai and get some blood work done, they charge you $500. You go to Lincoln Hospital, you get the same work done, and they charge you $200.
You're talking almost like the single payer system that everybody fights because that's exactly what you would have. It doesn't happen because the cost per visit depends on the institution, very frankly, what you're paying your doctors, what you're not paying your doctors, what you're investing in, things like that. And that's why they're constantly negotiating the rates from the insurance companies. It's an ongoing thing. And I was in the health department, and we would spend time on what is called the cost of a visit, and how much should they be reimbursed in the caps and things like that.
Hi, I just wanted to say something. With regards to the gentleman over there that said about the supermarkets, I mean, I didn't clearly hear him too well, but, you know, they blame everything on the supermarkets not having the proper food. I blame it on the individual, because there's a lot of farmers markets, like in where I work, we have the employees there. They order tea when we have hot water in the bottles that they bring to the office. So it's a choice for the people that they choose to eat like that. And lately, on another issue, I've been noticing that below 96th Street, there's a lot of urgent care clinics that are opening up, and that's because of what's happening in the hospitals and all the high charges that it's taking care of.
But they become part of networks that feed into hospitals too, so that's the other issue.
Simple yes or no. With the closing of the more community-based hospitals and, you know, some that we're more accustomed to in our minority communities, do you feel that down the road that they'll be having these Walmart hospitals, so that you just go there and they're these super hospitals that are pretty much prevalent, or do you feel that?
That's a hard question to answer, because we don't know what the science and technology is going to bring in terms of healthcare, number one, right? Number two, there's always a need for specialty care. When I talk about specialty, I'm not talking about cardiology and things like that. Specialty care is in terms of the people that we're serving, languages, right? Customs, being able to follow them in a certain way. A larger hospital is not going to be able to do that. You're right. In the Walmart situation, you go in there, you pay the cheapest price, and good luck. So when I talk about the holding the feet to the fire of people who are making decisions about hospital closures or even how we define quality of care, that's some of the discussion that has to take place. Metropolitan Hospital, for example, in this community, is a public hospital. Mount Sinai, first of all, could not take all the patients that they see. That would be impossible. Columbia Presbyterian could not do it. Lenox Hill could not do it. Bellevue could not do it. So there's a place for Metropolitan, and you have to, when you're doing planning, we have planners that look at hospitals and where they're based. The question is, how many beds does the hospital have? How many beds does it need? So when I talk about beds, for example, there's a discussion about, are there too many beds in the system? Meaning beds that are empty throughout the year, because it costs money. You're staffing those beds. Kings County Hospital when it was first designed to be reconstructed, had 1,000 beds in the first plan. That never happened. So they're phasing it in with 260, another 200, things like that, depending on the need. Same thing with Queens Hospital Center out in Queens, these are public hospitals. I just want to finish up. So look at how much money we spend. I'll get you, I promise. Look how much money we spend. Look how much money you are spending. Okay? Look how much money you are spending in New York State. This is not the United States. This is New York State. Look how much money the city of New York spends. That's not M, that's a B for billions of dollars. Okay? Look at the number of people that we have on Medicaid. We have 18 plus million people in this state. More than 5 million of those individuals are eligible for Medicaid. Look at the number of people in New York City who are eligible for Medicaid. Almost one out of every 3. So when you're looking at your neighbors, just look around. Someone in this room could be Medicaid eligible, maybe on Medicaid and things like that. Those are public dollars. Now I'm going to say this because I've been in this argument about diversity in healthcare. When we don't ask boards of directors or trustees to have minorities on their boards, and they are receiving Medicaid dollars, the fault is with those people that are voting yes or no on the budget for not asking the question. I've been saying this for years. So if we don't have representation in the community for hospitals that are serving our community and they're receiving public dollars, then the pressure must come from those who are voting yes or no. And I gotta tell you something, having worked in the legislature, you can easily, if you wanted to, if you have the guts and can persuade enough people, write a line in the budget that says, unless you have adequate representation that reflects the composition of the community on your board of trustees, you may not be eligible for Medicaid, or we will reduce your Medicaid. That's the given, this is the business of Medicaid, all right? Now when you're spending $58 billion, that's a lot of money. Now conversely, right, on the private sector, in the old days, right, you would go to your job and part of your benefit was health insurance. It's gotten so that we have to mandate now under Obamacare, right, participation by employers to offer health insurance to their employees. And even with that, there was a way that it was given an extension because some businesses could not meet the deadlines. So this trend is something that we have to watch out for, because if they're not doing it, then the public has to do it. Because unless we change our system, right, the insurance is what gives you the access to your health care. So that becomes important. I'm going to skip some of this stuff so you can get here. All right, this is for immigration. Some of you asked about immigration. So in New York State, okay, again, anybody who is enrolling, we don't share the information with anybody, not with the federal government and things like that about their status. And we offer emergency Medicaid under the old law, by the way. This is not even Obamacare. For anyone who goes in and needs immediate care, immediate attention. But you don't get his long-term care. That's a problem.
Like our shelter.
Yes. Right. Start with that. All right. This is the Health and Hospital Corporation. It's the largest public health system in the United States. Right? You see how many clinic visits they had? Got 8 million people that live in this city. They had almost 5 million visits to their clinics in 2012. Those are some busy clinics, right? And not everybody's paying. You have to understand that. So, we end with this, all right? Delivery of quality healthcare services and the reduction of healthcare expenses are in the interest of every member of this community. I'm hoping that if you didn't think that before you came in, I hope you'll leave with that thought. Second, elected officials they have to ask the questions. They're the ones that are sitting there. You need to hear and listen to what questions they are asking. And hold their feet to the fire about that. It's $58 billion of your money. Do they have the information? So if you go to the district office and you need to do some research, can they help you with that? Do they know? Anecdotally, they'll hear, just like she said, right? We're dying in our community, but we don't have the statistics. And in this world, it's very cold, so you have to be very scientific in your approach, and very academic, right? Now, stakeholders and stockholders. I teach this in my class all the time. You are a stakeholder. All of us are stakeholders in the healthcare system. We either benefit from it or we don't benefit from it. We use it, we don't use it, but we are stakeholders. But if I were to look at the business of government and the product is public service, then ladies and gentlemen, you are stockholders. And like any stockholder, you have the right to ask questions. Yes? Keep that mentality moving forward. Because if you don't, someone else could ask you a question and it may not be yours. Finally here. So yesterday we had the fanfare about Long Island College Hospital. But what was not said, see, so things I always tell my classes, things that are said are important, but what is not said is equally as important, sometimes more important. There was no mention yesterday of a guarantee that Long Island College Hospital or any hospital facility will be on that site. They are aiming for that. They'll weigh the bids on that, but there's no guarantee. And finally, Obamacare is not a guarantee that your hospital is going to be standing open for 4 or 5 years. It's not. So it's not the end all and be all. So don't look at the hospital and say, with all due respect for those of us who have worked in the hospital system, as the symbol of our healthcare. Look at the outcomes and how healthy we are. And then listen to the answer when you ask how you feel. And thank you for your time.
Thanks again, Manny, for a great lecture. Thank you all again for coming. A couple of quick announcements before you go. One, Manny and Jaime are both going to be available in case you need to talk to them after our session. The other thing is the PowerPoint will be sent out to you all. Be sure to check out our website, LatinoLeadershipInstitute.net. We try to post as much information as on there as well. And next week, be sure to come spread the word to those who you may have noticed weren't here today. We're going to be talking about educational policy with Dr. David Lopez, who is a phenomenal expert in this area. We're going to be talking a lot about, well, what's going on with policy now that de Blasio is in office. We're talking about a lot of like the public school versus charter school debates, state rights versus city rights. All the hot topics that are very prevalent going on and affecting our communities is going to be the topic of conversation next week, so you will not want to miss it. We can't always guarantee we're going to record everything because of a lot of things, so please don't rely on that and think, well, I'll be at home and I'll be able to get it. You might miss out. And so please come. When we do have them, we post it on our website, LatinoLeadershipInstitute.net, along with the PowerPoint. So check it out, and as always, I'm always available. I'm the one who you get all the emails from. I'm Cindy, in case you all didn't catch on real quick. We're always available, so please don't hesitate to reach out. Have a wonderful weekend. Enjoy the great weather. We'll see you all next week.
So I will not be able to make it to the next sessions. I'm not working. So I wanted to let you know in case there's other viewers that are interested. Great. Of course, I would just tell you if you can help us. Yeah, check the website out and our
This was good. I like it. Yeah, y'all did great. Come this way. For the price,
Oh! You help me again? How are you doing?
Thank you once again. Yeah, you heard my question. It's got to be always hot, right? It's always going to be hot. It's always going to be hot. I didn't think about it from that perspective that the public hospital always has its role. Just like we gotta have the bodegas, we gotta have the health food store, you know. And so there's always gotta be that. There's probably always gonna be a demand for these options. Oh yeah. Well, you pay $400. Yeah, I'm about to say. $400. Everything's like he gets covered for everything. He gets money. I believe it. It's just like if everybody gets money, so the quality is a lot cheaper, changing the oil, maybe changing the brake clean there. It's a lot cheaper than if your car breaks down, you have to change the whole car. My man, it's a humongous sushi. That's all it is. That's all it is. It's a humongous sushi. Just come in. It's not like it's good. I think really, really good class. Yeah.
I have it. I'll look over everything. I'll look at it. What's good, brother? Back in action? Good, busy. Came back in all the time. I'm just like, Candy, what's going on?
the fundraiser, yes. And I invite people, not just
Share with you like it'll be in June. So that to get the information out, to put it, yeah, exactly. So we're gonna get we're gonna start last Friday. Where we are, and then you can very important that we have kindness with university. So we'll be working with
Next one's gonna be good. Next one's gonna be good. Next one's gonna be good.
We are.